Let us look at section 13, diseases of the accessory organs of digestion. And then here, the session slides, we look at diseases that affect the gastrointestinal tract. And then this last section of the gastrointestinal system covers diseases that affect the accessory organs of digestion. And then specific diseases that we have to look at, hepatitis, cirrhosis of the liver, hepatic coma, and then cholecystitis, and then pancreatitis. At the end of the session, the student should be able to identify diseases associated with the accessory organs of the digestion. Diseases describe the disease, nursing management for patients with diseases of associated with these organs, and then identify prodromal manifestations suggestive of possible complications. So we look at hepatitis, cirrhosis of the liver, cholecystitis, and then pancreatitis. Some of the conditions here, we have provided extensive notes, and then you should be able to read on your own. And then we have given a lot of examples, especially under the hepatitis and then the cirrhosis of the liver, which are very common conditions in our part of the world. So hepatitis is the inflammation of the liver characterized by abdominal pain, vomiting, hepatomegaly, which is enlarged liver, and then jaundice. And then it is one of the most common liver disorders. Types of hepatitis according to pathology. So we have acute hepatitis having a severe and then rapid onset, a short course, and then pronounced symptoms. Chronic hepatitis, this is when hepatitis progresses for more than 6 months, and there are 2 types of this chronic type. We have these are chronic progressive hepatitis, which often shows a mild form of the disease in life of the patient, and then chronic active hepatitis, which often results in severe destruction of the liver. And the types of hepatitis according to etiology, we have viral hepatitis, and then the types, we have the hepatitis A, which is the infectious type, which is the RNA, and then we have the hepatitis B, serum hepatitis DNA, and then hepatitis C, which is non-A, non-B type, and then the hepatitis D, we have F, and then E, we have the G. And then apart from hepatitis viruses, other viruses can also cause hepatitis, including cytomegalovirus, and then we have the Epstein-Barr virus, and then the yellow fever virus. These can all cause. And then the most 5 common ones that we have are of the viral hepatitis are the hepatitis A, B, C, D, and E. And then here, this A, and this is caused by RNA virus hepatitis, specifically picovirus, and then it is transmitted by the orophycal route, and then transmitted to humans through methods such as contaminated food, water, and then poor hygiene practices or intimate contact with carriers of the virus are also sources of transmission. It's rare to be transmitted through blood transfusion, and then it causes an acute illness form, and then the patient immune system makes antibodies against it. And then the B virus caused by a DNA virus known as the hepatovirus, and then virus can cause both acute and the chronic forms. And then the identified methods of transmission include blood transfusion, now rare because the blood that we transfuse used for transfusion is screened, and then tattoos can also through that we can get the condition sexually through sexual intercourse or through contacts with blood or bodily fluids or in utero. We have hepatitis B, formerly known as hepatitis A. Non-A or non-B is caused by RNA virus. It can remain asymptomatic for about 10 days to 10 years to 20 years. No vaccine is available. We have D virus, the Delta virus. We have E virus, and then it's transmitted through orophycal route. And then we have the G. And then other causes of hepatitis, we have alcohol that can also cause it. We have toxic hepatitis, drug-induced hepatitis. These are chemicals or drugs on other substances that can cause the condition. And then we have the hepatobiliary hepatitis. This is produced by obstruction of the hepatobiliary tract. And then we have the metabolic hepatitis. Some metabolic disorders cause different forms of hepatitis. For instance, we have the hemochromatosis due to iron accumulation caused the liver inflammation and then the necrosis. We have autoimmune hepatitis, whereby the body cells fight against themselves, and then autoimmune responses. Substances are also embedded in the liver, and that can also cause a lot of problems in the liver. So pathophysiology of hepatitis. The major pathophysiology events in viral hepatitis is destruction of the hepatocytes with the inflammation, and then the virus invades the portal tract, periportal space, and then lobus of the liver, and then cause inflammation of the liver, and then destruction of the liver parenchyma or the cells in general. And so this results in necrosis, degeneration, and then autolysis of the individual hepatocytes. And so we can have infiltration of the liver by leukocytes and then histocytes, and that can easily occur. And so liver enzymes, for instance, we have the gamma glutamyl transferase, which is GTT, are released, and liver function decreases. And so the damaged hepatocytes are removed by phagocytosis, and then regeneration of the cells may occur. And so residual damage depends on the severity of the cause of the illness. Usually recovery can be expected with mild liver damage. And so clinical manifestation of this condition, the features of acute hepatitis can be labeled as pre-ecteric. We have the ecteric and then the post-ecteric, depending on whether there is jaundice or not. So based on the clinical manifestation, whether the patient has jaundice or not, we have divided this into three: pre-ecteric, ecteric, and then post-ecteric. So most of these clinical features which clients may show, malaise, we have the right upper abdominal pain. We may also have vomiting and then loss of appetite, dark urine, fever. We can also get hepatomegaly and then jaundice, which is a yellowing of the skin and then the eye. And then some chronic forms of the hepatitis may also show very few of the above signs and symptoms, and then are only present when the long-standing inflammation has led to the replacement of the liver cells by connective tissues, and this is known as the cirrhosis of the liver. So now, pre-ecteric phase of the prodromal stage, which is the early stage. Here we have eliciting manifestation of malaise, gastrointestinal complaints, including nausea, vomiting, diarrhea, anorexia, and then client or the patient may also complain of headaches and then fatigue. And then we have right upper abdominal pain, which may be elicited upon palpation. And here we are talking about the right upper abdominal pain, and the reason is that the liver is located or situated at the right upper part, and that is where exactly the patient will tell you that I have the pain. And then we have the ecteric phase. You know, the first phase is the pre-ecteric. Here, no jaundice, no yellowish coloration of the eye, and then the palm, and then other areas that are noted. But what we see in the ecteric phase is that the second phase is marked by jaundice of the mucous membrane and then the skin. And so the jaundice occurs because inflammation of the liver and the bile ducts prevents bilirubin from being excreted into the small intestine, and so they are embedded in the circulation. And so as a result, the bilirubin, which is the principal pigment of bile, is elevated in blood or circulation, and that is easily able to cause yellowing of the skin and the mucous membrane. And that is why patients with severe hepatitis, we have the palm becoming yellow, the lips, the eye, and the other possible places. In advanced stage, even the general skin may become yellowish. So when this happens, the patient complains of pruritus, which may then be caused by deposits of the bile salts on the skin because of the bilirubin in the circulation. Some salts are deposited on the skin surface. For instance, we have the sodium terichlorate and then sodium glycolate. These are chemicals on the skin that can cause a lot of itching. So patients with hepatitis at the ecteric phase are able to complain of severe itching of the skin, and these are the pathophysiology or explanation that we can have for this kind of manifestation. So the client frequently has a light brown or clay colored stools because the pigment is not excreted through the normal fecal pathway, and so instead the pigment is excreted by the kidneys, causing the urine to be dark and in some cases very brown and then concentrated. And so during the ecteric phase, the initial prodromal manifestation usually diminish even though the serum bilirubin increases. So for uncomplicated forms of hepatitis, spontaneous recovery may begin within 2 weeks of the onset of the condition. Now, the post-ecteric phase or the convalescence phase, when the patient is healing, this lasts several weeks, and during this time, manifestations gradually improve, and the hepatic pain and then may decrease, and then gastrointestinal symptoms and manifestations in general and weakness may go down, and then serum bilirubin levels return to normal, and then energy level increases, and the patient becomes well. We can do a lot of investigations. Here, diagnosis may be based on health history and then physical examination. And several investigations are also available to test for hepatitis. We can do anti-HAV, which is the antibody test, and found from the onset of symptoms and then persist throughout the person's life. We have HBsAg, which is the hepatitis B surface antigen. Several types have been discovered, and its presence indicates active disease or carrier case. And in most hospitals, if you have heard about hepatest, this is what we are talking about. We have the HDA, which is the delta antigen, and then detectable in early acute infection. Its antibody for HD is present with current and then previous delta virus infection. And then we have anti-HCV, which is the antibody for to HCV, formerly known as non-A, non-B, and seems to be most accurate in detecting chronic state of hepatitis. We have other enzymes reflecting liver function may also be done. For instance, we can do the ALP, which is the alkaline phosphate, which is a non-specific test of liver and is frequently elevated in obstructive jaundice or hepatitis. We have the gamma glutamyl transferase, which is the GTT test. It's a more specific test of liver function, but alcohol or hepatotoxic drugs also cause GTT to be elevated. We have lactase hydrogenase, and these are the enzyme tests that we can do when somebody, and then we have the bilirubin levels, which we can also do, and then the liver may not be able to manufacture the protein and needed for blood coagulation, so we have to look at that. Pharmacology, both pre-exposure and then post-exposure pharmacology are important. So pre-exposure, I have the notes here. I'll let you go through yourself, but there is something that I want us to look at, which is very important when patients have clinical manifestations of hepatitis, and then when we need to do second, what do you call it, major treatment at the hospital, and when they have all the symptoms and when the condition is critical. So we may start with IV fluids, and that is the secondary treatment. Yes, so the secondary treatment, when we have all these things, we need to ensure that we give them a lot of IV fluids. In some cases, we can give them dextrose water to give them energy, and then we can add Bico injection, and then we should also allow them to drink a lot. So we have liberal oral fluids if the patient cannot take the normal water, so glucose drinks is good, and then neomycin sulfate tablets tend to help this patient even when they are dying. Neomycin is very good, and then bed rest is very important, and then low fat diet, low protein diet, because of the kidney, the liver is weak, and then vitamin supplements may also help. And then complications, we have the hepatic encephalopathy, which is hepatic coma. In advanced stage, hepatic coma is a brain and the nervous system damage that occurs as a complication of the liver disorders, and this causes different brain and the nervous system symptoms, including changes in reflexes, and then changes in consciousness, and then behavior change that can also range from mild to severe. And so hepatic encephalopathy is caused by a disorder affecting the liver, and this includes disorder that reduce the liver function, such as cirrhosis or hepatitis, and then the exact cause of the hepatic encephalopathy is not known. However, when the liver cannot properly metabolize and then turn poisonous substances into harmless substances in the body, then these poisons build up in the blood, and this may cause. So one substance believed to be particularly harmful to the central nervous system is ammonia, which is produced by the body when the proteins are ingested. So ammonia is normally made harmless by the liver, but when the liver is sick or diseased, it means that it cannot perform this function. And so this tells us that when we are treating a patient with liver conditions, we should limit the amount of protein that is taken. Other than that, the problem is likely to affect the brain, and the patient may be having problems. So symptoms of hepatic encephalopathy, symptoms depend on the severity of the neurologic involvement, and so the disorder usually progresses through 4 stages, but the patient's symptoms can fluctuate from one stage to another. One is Prodromal Stage, and this stage, the patient's history obtained from the patient or from the family members may reveal slight personality changes, such as disorientation or forgetfulness, and then the patient may also have trouble concentrating or thinking clearly, and then he may report feeling fatigue or drowsy, and then he or she may also have a slurred or slow speech, and then on inspection you may observe slight tremors, and this may also give rise to the second stage, which is the impending stage. And so the patient undergoes continuous mental deterioration changes, and he may be confused and then disoriented as time goes on, and then place also may be affected, and then disorientation to person may also be affected. So tremor may still be observed, but progress to Accessory, and then which refer to a motor disturbances characterized by intermittent flapping movement of the outstretched hands up and down, and then size, and then size, and the irregular extension and the flexion of the wrist is also likely to occur. And then we have this Comatose Stage. The patient shows marked mental confusion. On inspection, the patient appears drowsy and stuporous, yet he can still arouse, and then is often noisy and abusive when aroused. And then we have the Comatose Stage, and the patient cannot arouse, no hysteresis, no seizure, but may occur. The patient often has fetal hepaticus, which is a musty, stuffy, or stale, or decayed, or sour odor breath occurring in the terminal stage of the hepatocellular liver disease. And so fetal hepaticus may occur in other stages also. Finally, the stage progresses to coma and is usually fatal. And so the patient should be placed in a coma position, and then if unconscious, lateral position with the head turned laterally to avoid aspiration, and then avoid protein foods, and then you also need to avoid sedation. No sedation whatsoever should be given, and then give nutrition with increased glucose content. That is very important. But let me show you one. At the Comatose Stage, the patient can be very, very aggressive, and they even can bite nurses who may be taking care of the patient, and at times they are very aggressive, and at times they bite their own tongue, and when you don't take care, they can injure themselves in the ward. But they become very aggressive, and at times you need to nurse them at the side ward. You don't need to bring them to the main ward because of possibility of affecting other patients. So when you see the patient with hepatitis very aggressive and becoming very abusive, then it means that the patient is going to the next stage, and that stage is the Comatose Stage, where they go into coma, and when they are in coma, they can easily die. And so we have to avoid that. And so at the stage where they are at the Comatose Stage, what happens is that you don't need to give them any sedative. When they are very strong and they are very aggressive, if you give them sedative, it means that you are pushing the patient to what do you call it, the comatose stage, and that is very bad. We don't need to do that. Okay. Okay. All right. So we continue like that, and then that is the stage that I've just explained to you. We don't need to move the patient to the comatose stage, because that stage is likely that they may die. So we have to avoid that. So nursing care and the management in general, nursing care, management of hepatitis, risk of infection transmission is very important. So one of the important goals of care for clients with acute hepatitis is preventing the spread of the infection through universal precaution measures, and then for clients with hepatitis A and G, use strict barrier nursing, which is isolation, and then clients with hepatitis B who are bleeding should be also isolated. So universal precautionary measures very important. Activity intolerance, fatigue sometimes accompanied by weakness is common in clients with hepatitis. Adequate periods of rest is also very important, and then altered nutrition. Sufficient energy is required for healing. So adequate carbohydrates, and then spare protein, which can cause body image disturbances. Jaundice, rashes, and pruritus may also cause client embarrassment. So care focused on prevention of skin breakdown, and then improve image. Client teaching based on teaching about the disease, methods of prevention to prevent transmission, and then avoid hepatotoxic substances like alcohol and then other drugs. Follow-up care or review is very important. So we have to discharge, do discharge planning, and then explain that until surgical indications return to normal. Sexual and then close contacts may also be with other contacts like wives and the husband should also be avoided. Let us look at cirrhosis of the liver. Cirrhosis of the liver, once we have done hepatitis, let me give you, it's a reading assignment, and then I want you to do a lot of reading on cirrhosis of the liver. We have the definition. I've given you the definition, the types: alcohol cirrhosis, post-nephrotic cirrhosis, we have the biliary cirrhosis, and then we have the cardiac cirrhosis, and then clinical manifestations. I have provided you with most of them here. You have to read on your own, and then the onset is usually insidious, and then read on the effects of the cirrhosis on the following systems: integumentary system, neurologic, gastrointestinal, hematologic, circulation, cardiovascular, metabolic, and then reproductive system. And the diagnosis points at physical examination: the skin, look at the abdomen, eyes, breath, and then the concentrated urine is then the laboratory investigations in cirrhosis. We look at the serum bilirubin. We have to also look at the prothrombin time. In most cases, we have bleeding tendencies, so we have to look at the prothrombin time, and then others, and then radiographic evaluation, ultrasound, and then the CT scan, and then other things. Treatment generally, liver damage from cirrhosis cannot be reversed, but treatment could stop or delay further progression and then reduce complications. Alcohol cirrhosis is treated by abstaining from alcohol. Medications that reduce itching may be given, but with care not to induce sedation. Antibiotics may be given for severe infection, pneumocin, and the massive hemorrhage require blood transfusion. For portal hypertension, propranolol is a commonly used drug to lower blood pressure over the portal system. Nursing management: encourage bed rest, observe bleeding, and then advise on skin care. Read on complications: bleeding, hepatic coma, and then jaundice, itching, and then prognosis. We know that alcohol cirrhosis has a worse prognosis than primary biliary cirrhosis, and then cirrhosis due to hepatitis. And then please read on cholecystitis and then cholelithiasis in general. Okay, so I have the notes here, so later you can take your time and go through. I've provided the incident, pathophysiology, signs and manifestations, and then the diagnosis in general, and then medical treatment, and then surgical management partially, and then nursing management, and then complications, And then pancreatitis too, we have the definition here. What is it? And then I have a picture showing you the pancreas, and then we have the types of pancreatitis, and then we have acute, and then we have the other types, and then the etiologic and the pathophysiology of acute pancreatitis. We have the pathophysiology in general, and then we also have chronic types or chronic pancreatitis, and then we have defined it, and then when does it occur, giving you etiology of and pathophysiology. We have given that as part of the notes. We have to treat, look at that, and then we have the hereditary pancreatitis, and then symptoms in general, and then nursing care in general, which we have 1, 2, fluid balance and nutritional status, which we need to look at the improvement of respiratory function, patient education, and the home care. These are very important. And then I want you to read on the surgical procedures for pancreatitis, and also read on hepatic coma. I have other references for you to check. Thank you very much.